So now I'd like to introduce our moderator, Marnie Leonard. Marnie Leonard joined. Come on up. All right. And I got some stuff to talk about you. Yeah, the twirl. Yeah. That's right. She's on the board. She's. So Marnie joined Multicare Health System in April of 2016 as a finance officer at Tacoma General and Allen Moore Hospitals. She transitioned to the Multicare Good Samaritan Hospital as their chief financial officer in March of 2019. And it doesn't say it here, but I know you spent years at Providence because we worked together at Providence as well. And so, Marnie, it's all yours, and you've got a mic.
All right. Hi, everybody. Good morning. Your host today. Am I on?
They'll turn it on.
Okay. Well, there we are. All right. Well, we're going to have some fun today. I'm so excited. I got the opportunity to be asked to be on the panel back in November, and it was just a really great experience. I think the CFO panel is, it's a little real, it's a little raw, and you're getting it unfiltered. So I think this is a really unique opportunity. So I really want you guys to definitely jump in and ask your questions. We're going to have plenty of time for discussion today. We're in a small enough setting that we can have a lot of back and forth. So please don't be shy. We want to hear from all of you. So I'm really excited to introduce my fellow panel members. We actually are missing Sean Douglas. And I think I'm going to get a new mic, maybe. I see somebody running. Yeah, thank you. All right, trade. Ooh, I like that one. Okay, so I'm going to introduce my fellow panel members, but because Sean's not here, I might also be jumping in with some additional thoughts as well, just to give a little bit more CFO perspective on what's going on right now. So I'm first going to introduce Richard. Richard Boggess, come on up. He is the CFO for Arbor Health and a longtime HFMA volunteer participant aficionado. So we'll be doing introductions after everybody comes up, and we'll get to know him a little bit more, and he's going to reveal all of his secrets, right?
That's right.
All right, so I would also like to introduce Jennifer Reed, who is the COO and CFO for Ferry County Health. So welcome. We are so happy to have you. You're going to do amazing today. We can't wait to hear all the amazing things you have to say. No pressure. All right. We're very pleased to have Ketty Hsieh. Is that right? All right. Polyclinic, Vice President of Finance. We are so blessed to have her and her busy schedule. So thank you so much for joining us. So this is your magnificent panel. So here's how it's going to work. We are going to not have a game show, but we are going to spend about 15 minutes really getting to know everybody, so you can kind of hear a little bit about our organizations and background. And then we're going to go into probably about 30 minutes of pre-planned questions that the team has spent a lot of time giving some thought to about what's on our minds and what we want to share with you. And then we're going to open it up for the remainder of the time to for you guys to ask questions, put us on the spot, put us on the hot seat. Any question is open. And then we'll kind of let it flow and see what happens. So does that sound good to everybody? All right. So Jesse already did a nice little introduction to me, but I'll just add a couple more details. So I've been at Good Samaritan for the last 3 years, and it's a 375-bed licensed hospital in Puyallup, Washington. We have a inpatient rehab facility. We see ourselves as a community hospital. We serve a very large geographic area. We are the only acute care provider in East Pierce County, and we kind of really serve all the way out to Mount Rainier. And so just a wide variety population. It's growing. We are really focused on making sure that we just keep our patients within our community, and we believe we provide great patient care. We are really focused on our patient experience and creating that world-class experience. One of the things we do is our executive team rounds on units every single day. We kind of swarm a unit every day, and so that's what our focus is. A little bit about me personally. Jesse talked a little bit about my career. I worked for Providence. I was at KPMG before that as a financial statement auditor, where I found my love for healthcare and its complexities. I have 3 boys, 13, 11, and 6. And so I'm very, very busy. I just adopted 2 dogs and started an Airbnb this fall, and teach dance. So my life is very busy, but I feel very, very blessed. So that's a little bit about me. Richard, would you like to introduce yourself?
Sure, happy to. So it's always a dilemma, right? How far back in your history do you go to share with folks to be relevant? But since you asked for the details, we're going to go there. I've grown up all over the U.S. Born on the West Coast and lived in Oregon for a while, and then went to the Midwest. And when I finished high school, I thought, I really like computer programming. That's really cool. I'm going to get into that. And it took a couple of years. I didn't go to college right away. I worked in family business, and that's when I ran into doing finance, managing the family business. And I thought, wow, you can really move these numbers around quite a bit to get a different outcome. A la cost report. We won't talk about Enron. We'll talk about cost reports, right? But it was quite an experience, so I ended up going to college for that and ended up with Advent Health out of the Southeast. It's a large religious organization, 19 hospitals, plus the number 1, 2, or 3 hospital in the nation for delivering Medicare business, depending upon what year you look at. Of course, you can do that when you've got 5 campuses under one provider ID, right? So anyway, I worked with that organization for a while in their finance department at one of their outlying facilities, which wasn't part of the mothership. It was still under that brand. But, and that's where I sort of took that love of IT and married it with healthcare, or with the finance side, and ended up moving into decision support after about 5 years, and became the cost accountant for what they call the multi-state division of Advent Health, which is about 15 hospitals, and built their cost accounting system. And that was a challenge, but that continued to grow. And anyway, they got to a point where they needed a CFO at one of the outlying hospitals. And this is the funny part of the story. I heard several years later that the story at the corporate office was, well, which one of the Boggesses are we going to send to Manchester? Because my wife is also a CPA by training. But like I tell everybody, healthcare or finance is very different depending on what side of the ship you're on, because she and I take different approaches to solving problems. And that's good. We need that variety. Anyway, I ended up at Manchester. We started a family, and I have 2 great kids now. I have a senior graduating high school, and I have a sophomore that is on his way to the Washington State tennis tournament to be in the finals. So he's at state. So we're real excited about that in my family. Moved around that part of Advent Health, Texas, ended up in Colorado for a while, and now I'm out here. I work for Arbor Health, which is a critical access hospital in South Central Washington State, and everybody's like, where's that at? So, we are in between Mount Rainier and Mount St. Helens. So that gives you some geographic perspective. So when the mountain blew back in the 80s, they got a lot of that experience. So that was an interesting experience for them to share that with me when I arrived. I've been there, I'm coming up on 6 years, and it has been quite an experience. We're doing all kinds of interesting things. One of my goals coming up through the healthcare system was to be the CFO of my own organization, and don't have that corporate overhead where I always have to, there's a lot of value in that corporate overhead, and we'll probably talk more about that later, but when it's you and you're in the CFO slot at a small hospital, it's you, and you got to know where your resources are at. And so that's always fun to network and talk to other folks. And I think that covers it.
Thank you, Richard. Another finance CPA at home. You guys must have some riveting discussions at dinner.
She's involved in a lot of community type things, and so I get to hear about some of the challenges that various organizations are having, and yeah, it's interesting. But it's nice to go home, and I will always remember this. I'm very close with my family, and my father said to me as we were getting married 20 plus years ago, you know, you will always have something that you can talk with your wife about, and that's finance, because you both are in that world, and so you know what that's like. And so, yes, I have come home and said, you won't believe what happened, blah, 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 blah. And she's like, well, think about this. And I go, oh, because people are different, and they have different approaches to solving things. And so it's really nice to have a spouse who can help sympathize with your dilemmas.
That's fantastic. And I always tell people finance is fun, right? Finance is fun. It's not scary. So I'm sure there's some good discussions around the dinner table.
Oh, yes.
All right, Jennifer, would you like to tell us a little bit about yourself?
Does this work?
Just hold it up.
Does this work? Okay. I'm Jennifer Reed. I am the CFO COO at Ferry County Health. I come not from healthcare, really. I'm a newbie at 10 years or so in the healthcare finance world. I was a consultant before that in the Seattle area. Hello. And just happened upon a consulting job for 6 weeks at Whidbey Health on Whidbey Island, and ended up there 9 years later. So I came up through the ranks, cost accounting, staff accountant, accounting manager, and finally director of finance there. Very large critical access, and then just very recently went to Ferry County Health, which is completely different healthcare setting, and as far as rural health and access to health. Our county is about 7,000 people, and our town is about 1,000 people, but we do indeed have a hospital and a rural health clinic and rehab, and we have specialty care that comes to visit. Let's see, what else do you want to know about Ferry County Health? I don't know, you'll learn later about Ferry County Health. So about me, I have 4 children, 3 grown children. I call them my other kids, and then one I have 12 years later. He's a 16-year-old in high school now. And then I have a little 18-month-old granddaughter who I really love very much. And so I guess that's me. So you'll learn a little bit more about me, and I'm really happy to be here on the board of HFMA, and happy to be here.
Welcome. Thank you. All right, Ketty, you're up.
All right, good morning, everyone. So I'm Ketty Hsieh. I'm the VP of Finance for Optum Western Washington. I have finance oversight over both the Arbor Clinic and the Polyclinic. We are about a 700 provider or clinicians organization, multi-specialty. So for those of you who live in this area, you probably have heard about Polyclinic or Arbor Clinic. You probably did know that they both are owned by Optum now. So we're going through a lot of transformation. So my career path, I also didn't start with healthcare. I spent the first half of my career actually in transportation, mostly airline, short stint with the Greyhound bus as well. And then I thought, wow, I'm going to try something new. So I went to this great organization called Washington Mutual. I remember that. It was it was a pretty interesting 3 years, all the way to the bitter end. And then after that, I kind of just accidentally landed in healthcare. And I always say that I landed in healthcare by accident, and I stayed because I really, truly love the complexity, love the people I work with, a lot of great people, great minds. So at the healthcare, I started at Northwest Hospital, up kind of in the North Seattle area. Eventually, I was promoted to the site CFO there. They were part of UW system, and I was the finance head over there. And then after that, I left and went to Group Health, then became Kaiser, short stint at Providence, and now I'm here at Optum. So that's me. I have 2 kids. One just started freshman college. I guess she's she's a freshman, and I have a 7th grader. Yeah, I can't believe I have a college kid. Really, I don't feel like I should have. So, yeah, it's me.
Excellent. Thank you. Well, as you can see, we've got a wealth of experience up here. So excited about what we're going to talk about today. So I'm going to start out with talking about labor, because that is definitely the hot topic that is on a lot of our minds as we think about retention and labor costs. So I read a couple articles. One was from healthdive.com and talking about the Great Resignation. So in November of 2021, we had 4.5 million people quit their jobs. Within healthcare, the quit rate was around 6.5%. Those reporting a lot of high levels of burnout. From January 2020 to January of 2022, when this article was published, the pay rates for nursing staff had gone up for agency 67%, with bill rates from those agency and staffing companies being about 30%. So one of the significant challenges, that we're facing is certainly high labor costs. Another thing I read was from a different article was in Wisconsin, there is a healthcare organization that actually put in a court injunction against staff moving from one hospital to another hospital because they didn't have a staffing plan in place to be able to address the high level of people leaving. And we see that as healthcare systems and medical groups are competing against very, very, very scarce resources. And we certainly, the other thing we're seeing in the marketplace is a lot of union activity and a lot of passion around this area, specifically as we think about burnout and compensation and those types of things. So we're going to open it up to our panel, and we'll probably start with Ketty, if that's okay. Just talking about her experience, her systems approach to addressing staff retention and cost management, and anything new and innovative you guys are thinking about.
Well, we certainly are struggling just like everybody else. I think between the two organizations, between Arbor Clinic and Polyclinic, we have probably about 500 open positions right now out of I think our staff total is about 3,000, 3,500. So it's a huge number, and it's always the continuous churn. And we know that a lot of our competitors in the market are giving staff retention bonus and a huge sign-on bonus and so on. We have so far resisted giving retention bonus because we feel like that's more of a short-term solution. It's like an arm race. Where do you stop, right? You keep throwing money at people. We are doing sign-on bonuses for recruiting, which has been helpful a little bit, but it's like just try to keep up with your neighbor, how much more you can throw there. So we're looking at different ways of doing business. So for example, at the Polyclinic, we're looking at more consolidated and centralized front desk, check-in, scheduling, all those functions, see how we can centralize and be more efficient instead of having every little specialty have their own, front desk people and so on. So that's one of the things we're looking at that should help us gain some efficiency in the back office. So for example, in finance accounting, we become a lot more flexible in terms of where we recruit folks. So I know when I first started at this job last year, I've only been here for about a year, just in the finance team has about, I think it's like 22 or 23 people. At the peak, I had 7 openings just in a team of 22, 23. So you can see that's huge impact. So we become more flexible in terms of the location of the teammate that we hire. So several of the new recruits are actually located in other states. And we're fortunate because we're part of Optum, we're part of the national system, so we have the luxury of hiring people remotely because Optum has operation in pretty much every state. So it's not a problem for us to hire people and deal with the payroll implications at other states. So we're fortunate to be that large system. But we have been more successful once we decided, we can just look at people nationally. Some other Optum colleagues see the job, but they may be located in Colorado and they want to join our teams. Like, great, So, and it has been pretty. It had been pretty successful, at least from a finance and accounting perspective. I constantly work with folks who are in all the time zones, all the way from the East Coast to the West Coast. I pretty much cover all the time zones, and has been actually working pretty well for us. I think one of the challenges we face is we hear from our teammates is sometimes when they're remote, we still have glitches in terms of connectivities and systems, and that's unfortunate in this day and age, but that's something that we just continue to work with IT to address. But I think from a clinical standpoint, it is harder because you have to be on site, but we're also thinking about, for example, revenue cycle billing services that do you need it located on site or locally, or can you also, again, in our case, we can capitalize on the national team and see how we can centralize to get more efficiency that way.
You talked a little bit about sign-on bonuses. Do you have kind of a minimum commitment for those sign-on bonuses?
I think so. I can't tell you exactly how much. For the front line, we're looking at, I think anywhere, depends on the position, anywhere from like 1,500, like for MA, for more or the PSR, the patient front desk patient reps to, I think, upwards of 10,000 for nurses and more skill.
Great, thanks. Jennifer.
Yes, so we have the extra added bonus of being very remote, and our pool of people is less, very much less. So I guess a good thing about the pandemic is that we've all learned to work remotely a little better, and so that is an option for some of our back office staff. We do a little bit of remote work that way. Trying to compete with the big guys is hard, and we have not, on the other hand, avoided retention bonuses, just thinking about keeping our staff that's there already, and they see these huge rates that we're having to pay, and they see these huge sign-on bonuses. So we have actually focused more on retention than the recruiting side as far as spending money. And so we have given retention bonuses and raises and raised up all our lower level jobs to a living wage. So we're looking at a living wage. So that's what we've done there. And on the clinical side, we're really looking at homegrown and training programs for all sorts of PTs and OTs and train-the-trainer programs. We have pharmacy tech issues, and so we have a pharmacy tech that's doing a train-the-trainer program, so she's going to be able to raise up the techs within our organization, that with phlebotomists and pharmacy techs and the OT, PT techs, assistant position, really working on raising them up internally, and then reaching out to our school districts to get some interest in the healthcare field, finance and otherwise. We had a lunch and learn. I don't know, were you on the lunch and learn? And there's some other rural hospitals that are really doing some neat things with their local school district, so we're looking into that. So just trying to really keep the people that we already have happy, and looking at growth for themselves has been very important too. So that's what we're doing.
Thank you. Richard.
You know, one of the things I love about living in the West is how you can be rural and still be close to urban, right? And so I told you, we're in southeast Lewis County, but we're close enough to Puyallup. From Morton, you can be in Puyallup in less than an hour. And so if you have people who live on the north side of Morton, in like Mineral in that area, they can go to work at Multicare or Providence facilities, but they are choosing to work for us. And that's all great until you get to something called a pandemic, and wages start, get into a wage war, and they start looking around and going, wow, I'm making $35 an hour, but if I go over there, I can make $50. And that's a real dilemma for us to be in. And so, while we have that rural environment, we've also got to compete with that urban side. And then you enter government regulation, and on top of that, and we actually had nurses and other staff members say, you know what, I've had it with the state of Washington, I'm moving to Idaho. And when you're in a rural environment like you are, it only takes 1 or 2 or 3 people to really change the dynamic of your workforce in certain areas, and we experienced that. And so then we got into you talked about the agency costs for staffing. We get into that windmill, and that's a real challenge too. So what did we do to try to address that? We tried to refrain from retention and sign-on bonuses at the beginning, because that just, as Marty said, just amps up the process, and pretty soon you're in a bidding war. And we did end up in bidding wars on some of these hard-to-fill positions. But really, it's that core group of people in our neighborhood that really see us through. And so we ended up coming up with some creative staffing ideas, trying to work through that with the unions that we have representing those staff members was a challenge. But at the end of the day, I think most people came together and said, yeah, we have to take care of business and we got to get things done. And so that was refreshing. Recruiting is always tough because, like I said, we have some staff members who live on the outskirts of our service area because they want to be able to have, when they're off, have a urban lifestyle. And getting them so recruiting into that type of environment's a bit of a challenge, but we've been able to do it in most positions. I think respiratory is one area that we've really had a challenge. And of course, respiratory is so critical over the last 2 years, right? That is really the crux of, one of the outcomes of the pandemic. So working through that has been a real challenge. I'm so glad that the nursing team or the clinical team were battling that front and not me. But on sides like patient access, it's been pretty calm at our place. I don't think we've had a lot of, the challenge has been staffing when people get sick on the non-clinical side. I think about our materials team. I think both of our materials folks got sick at the same time, and all of a sudden my controller's down there trying to distribute supplies to the floor. Or if we have screeners that get sick, I spent some time out on the front door, greeting people coming in, checking temperatures, things of that nature. And that falls under other duties as assigned, right? But I must say it was a very enjoyable experience. I was really thrilled that I was able to move my day around that day to get out and greet the community as they were coming in. And staff walking through the hospital were like, "You're up here today? What are you doing out here?" And so, I think it goes back to that idea of getting back out with the staff. When the pandemic started, there was a big push to go home for whoever you could push home to reduce the footprint, right? I subscribe personally to the theory, if I'm administration, I probably need to be visible and on site. And so that fell right in line with being at the front door. When I'm the AOC, the administrator on call, I am walking the facility. In fact, we have some staff who say, "You must be AOC because you don't show up over here very often unless you're on call." But, I tell them, it's nice to know, that nurse who's going to call me at 3 o'clock in the morning, it's nice to know what she looks like and for her to know who I look like, because that builds that esprit de corps, if you will, so that, that I tell them, I'm here to be your resource, I can help you. I can't help you take care of the patient, but if we need to call the ambulance company to come and get folks and they're taking their time, I can be that bat for you and help make that happen.
Great, thank you. Some things I might just add. So our hospital, we currently have about 320 travelers right now, which is significant. And it's very painful, right? Because we're in a situation where, we're just coming off surgical titration and, the labor rates have increased so much, it's really putting a lot of pressure. And some of it stems from, we expanded a couple years ago and added 2 additional floors, and we just didn't have, the labor market was short then, and so we've kind of been in this high reliance of agency. But, in addition to that, we've had a significant amount of ICU burnout. I mean, we had, at one point, we were close to 200 COVID patients in our hospital. They were pretty much half full of COVID patients. And, a lot of our agency staff, or a lot of our ICU staff have significant, PTSD from what they experienced. I mean, very, very traumatic. You're seeing very young people who have children losing their life, right? And it takes a very, very big mental toll on those folks. So some of the things we've really tried to invest in is a lot of self-care for our staff, a lot of wellness programs. We have a harpist that comes in and plays music therapy for our teams. In terms of kind of how we're trying to peel ourselves out of this, one is, we did have FEMA staff for a while, and so we're starting to scale that back. We're starting to see our ED volume soften, so working on trying to reduce travelers in that area specifically, but our census is still very high. I mean, we still have a very sick population that we're taking care of. We're looking at innovative staff schedules. So, a lot of nurses and clinical staff don't want to work 12-hour shifts anymore. They want to work 10-hour shifts. They want to work 8-hour shifts. They don't want to work full FTEs. And, right now, they kind of have the ability to demand what they want. And so, just trying to find that right balance between what's sustainable, financially, but making sure that we're meeting the needs of those that we're trying to attract. Some other things, we've done, similar things like the sign-on bonuses and recruitment bonuses, but also just trying to become better operators in terms of managing every dollar. So we've put a lot of focus in our missed meals and breaks. We want to make sure that our staff are getting their breaks and they're getting rest, but that's also dollars that, translates to the bottom line. We were very, very highly reliant on incentive pay for a very long time because we were so short-staffed. I mean, we were, running at 130% of our licensed bed capacity. We just didn't have enough staff, and it was kind of all hands on deck. And so we were, trying to incent people to come, and so we've really had to scale that back. People get used to that, and so we pulled that back actually last fall. But there are still some really, really critically low areas like respiratory therapy, and even our operating room where we're trying to backfill all the surgeries that were stopped for a couple months. And peri-op, it takes a really long time to train peri-op staff. And so, how do we figure out how to get the backlog and be able to staff those ORs? So those are some of the things we're thinking about. But certainly, it's probably the thing that keeps me up and is on my mind constantly. Yeah. Hang on, let's get you a microphone.
Okay.
But thank you for jumping in for a question.
Yeah.
This is interactive.
I can't be loud enough for the internet, though. So my question. Let's go ahead.
Keep talking.
It's up. Try it now. Can you guys hear me? No. Hit the button.
It's green. We'll get you another one. Just be patient.
Thanks, Richard. So my question was, as as CFOs, how do you help the team scale back traveler roles, or what can you do? Are you past that point where you're willing to pay anything to get anybody to come in, and are you back to controlling some of that spend? Is there a plan to get back to controlling some of that spend? Is there, where are you guys at in that journey? I'm sure you can't just flip a switch and all of a sudden be draconian, but you can't let this go on forever. That's an obscene number of travelers. It's crazy. You have to do something.
Well, I can answer for my organization, then you guys can jump in. Yes, we are scaling back. We're looking at pay rates weekly because traveler rates are starting to come down. And we're also, again, aggressively coming up with strategies in terms of trying to recruit others, as well as drive our residency programs and drive new partnerships with education organizations. And there's a number of different strategies we're doing there. But also just trying to really spend some time figuring out how do we keep, because what's happening is people who are employed are actually going to work for agency companies, and they're staying in the same hospital, right? And so how do we create those benefits that really are going to speak to our employees? And you have a different generation of staff these days, right? It's less about loyalty, and it's more about what am I getting for it? And so it's also about how do you people want to work for good bosses, and so how do you continue to create those relationships? So yes, we are scaling back and reducing them pretty quickly. Just really tight position control processes and knowing exactly where you stand. But we absolutely have to do things differently and that's where I think those innovative schedules will help us.
I would agree with Marnie that it takes creativity to get through that. So the short answer to the question, though, is every one of those agency contracts normally has a timeline attached to it. And so whether it's 6 weeks or 8 weeks or 13 weeks, there's an end in sight, assuming that you can manage the other side of the shop. And so volume is probably a big indicator of, how do I have to scale up, and then when can I scale back down? And I've experienced that in my previous roles because, so I'll just vent a little bit. Earlier in the pandemic, there was this big discussion about hospitals are overflowing with patients. Well, I came from Florida, and let me just tell you, in Florida, from probably September, October, all the way to March is flu season, right? And I can tell you that there are patients who come and spend their entire ED stay, a 4-day length of stay, in the ED. That was happening 20 years ago. Hospitals know how to deal with that type of activity if they're in that market. It's probably a little more challenging in our markets where we don't see that type of fluctuation in the rural. So that is a dilemma to work with. But there's smart people in healthcare, and they know how to manage through that scale, through that volume up and down. And we don't necessarily need a lot of legislative heavy-handedness coming in to try and drive that. And granted, those folks are looking at a big picture too. The old saying is, don't throw too many stones until you've walked a mile in my shoes. So, I haven't been in their shoes. I don't know what things they're thinking about. I can only imagine, but I know the shoes that I've been in. So managing to the term of the contract, making sure you stay in line with your volumes. You're going to have challenges with wage creep. That happens every year, and it gets more exaggerated when we have these big bubbles like we just saw. I guess that's enough.
So in my organization, because we mostly operate in outpatient ambulatory environment, we actually have resisted using travelers as much. We have some for sure, but not to the extent. We have very tight position control process that we instituted last year. And I think what we have been doing also is that we have been constantly doing market kind of market review of the pay rates for all of our different support roles, different jobs, and so MAs, PSR to patient reps, and so on. That I think we just recently take a look, and we because we actually have some, we're not unionized, but there were some union activities, and we just did pull some data to show the employees how much we have really done for them. And I think for a front desk PSR, we have increased their pay by about 30% over the last 2 years. I mean, it's staggering, but that's also what's, but we kind of have to do that. I said before, we have resisted using things like the one-time retention bonus, that type of things, but what we're doing really is making sure that we keep up with the market and we can show the employees that's what we're doing. I mean, it's hard as a finance person when you see those numbers, because as you all know, that our revenue is now coming in 30% higher. So we just have to figure out how we can operate more efficiently, effectively, and deliver the care that we need to deliver. It's hard.
Right. Yeah. So thanks, everybody. Labor is definitely on our minds, hot topic. I'm going to transition us a little bit now. Yesterday, we heard from Anne on the teams at Evergreen a little bit about service lines and service line opportunity. We, in the activity-based costing, we talked about looking at profitability by DRGs and for certain services. We want to spend a couple minutes talking about how we engage our clinical partners in some of the work that we're doing as finance leaders, and how do we make those connections? What are the structures we have? How do we translate the financial information for those partners, and how do we get the right engagement? So Jennifer, why don't I start with you?
We don't say productivity pay.
Bad word.
No. So for our providers, we're small enough. We have 9 providers in the whole hospital, and we just have a personal relationship. And I've found that asking them what they want to see as far as finances has been my best gate. Because I can talk all day about finances, right, and their eyes glaze over, and they don't care. But when it comes to their pay, they do care. So when I say about productivity pay, I joke, but it really is true. We try not to go there, mostly because we don't have necessarily the volume that it would take. But so yeah, it's a personal relationship. I'm small enough where I can actually do that, and I know my providers, and so that's what we do, and just asking them what's important to them.
Great, thank you. Richard, you're up.
I'm up. Okay. Provider pay is always a challenging topic, and again, it probably comes back to the market that you're in, because I'm in the same boat as you are, Jennifer. That, with less than 10,000 lives in a market, it's hard to always make sure your docs are performing at a certain level. Not just docs, even any type of provider. So you try and find that happy medium. I've been at other organizations where the market they're underprovided, I guess maybe might be the term. And so there's a constant demand for physician services, and we've had to develop compensation scales based on national data to help those providers not give away the shop, but pay them appropriately while maintaining the compensation scale evenly throughout the organization. So that is always a challenge. There's 100 different ways to approach that, from fixed labor for fixed contracts at median based on MGMA or AMGA data to some type of productivity scale. Looking at the other side of the shop, though, how do you interact with your department managers and those kind of folks to help manage labor costs? I will always remember one of the first budget experiences that I had at a hospital in eastern Kentucky. And being part of Advent Health, there's always a big focus on productivity in that market. What's your hours per unit of service in med-surg? Are you at 10, or are you an 8, or where are you at? There's always a push on that. And so I sat down with the manager of the med-surg unit and started talking through her budget. And I just kept asking her, so what are we going to do about labor? Because here's where productive hours are in our region. You know, there's 4 other hospitals. Here's all of Advent Health, and we're in the upper quartile. How are we going to get back down closer to median? I just kept asking her that question and coming back to it as we worked through the budget. Finally got her down to 6 hours a day. And I know that's almost unheard of now, but if you think back 15 years, she's just like, I don't know how I'm going to do that, Richard. And so we got to the end of all her departments, and she goes, what else am I going to do? I mean, what else is left? And I said, well, we still got one more thing to do. We need to go back and talk about your hours per unit of service on med-surg. And she goes, I've already given you everything. And I said, I know, and I'm really appreciative of that. In fact, I'm concerned that you've overpromised. And doing a budget is not just about finance trying to drive you down to the bottom line. It's about coming up with something that's meaningful, that we can work with, that sets the right expectation for the organization, something that's achievable for you. And so we need to move that number back up. And she about fell out of her chair. But I mean, it's those kinds of experiences with department managers that help build that relationship so that when you get into the tough times like we're in now, you can say, listen, we need to do something different. So we need to think outside the box for the next quarter to figure out what it is we need to do so that we can get to the next quarter. And so, you know, those are some of those experiences that I prize in my career that I look back at. And I still stay in touch with those folks today.
Great, thanks. Ketty?
Well, I think working with clinicians is really just like working with any other operators, other functional leaders, that you just have to build that relationship. I think it's, you know, gain understanding. Again, unfortunately, I'm working in a little bit different environment where the 2 large medical practices, they have been independently owned and operate their own business. They're all physician-owned until recently. Polyclinic became or sold themselves to Optum in 2019. Everclinic sold themselves to DaVita, I think it's like 2016, and eventually then they got sold to Optum. But in any case, the physicians are actually, for those 2 groups, they were owners of the organization. Most of them were, and they are actually have pretty good business sense. So I'm very fortunate that. But that said, I still think building the relationship is key, right? So I'm talking to our CMOs, both the Optum Washington one, the Everclinic one, and the Polyclinic one, pretty much at least on a weekly basis, if not on a daily basis. We're working on some physician comm. You mentioned physician comm. We're on this mega physician comm redesign project this year to align the comm structure for the 2 clinics because they are completely different. And that has been quite interesting. We have a team of physician leaders partnering with finance and also our national comm team, kind of all working as a small working group. We have some really intense meetings, a few hours every week. And it's been going on great. I think it's building the relationship, building the rapport, really making sure that we see each other's points, right? And at the end of the day, we wanna pay them fairly and competitively, but we also want them to understand our restrictions. So, you know, we're going in and have very, very clear guiding principles: market pay for market work, and also the funding pool is now changing. We don't have budget. This is not a redesign to give everybody a 20% increase. You know, so very, very clear on what our objectives are, and I think that really helps. And like I say, just building that working relationship like you do with all the other functional leaders.
Great, thanks. All right, I'm going to shift topics a little bit and talk about looking to the future. So one of the roles of the CFO is being a thought partner with the leadership team to be strategic and grow our business and transform healthcare in the communities that we're serving. So we're going to talk a little bit and hear from the panel about what they're doing to transform healthcare in their markets, but also talk a little bit about how the changing economy is impacting our ability to transform healthcare or to deliver good operational excellence, access to to capital, those types of things. So, Ketty, do you want to start us off?
Okay, so in our organization, there are a few things that we're focusing on. One is value-based care, of a lot of you know about. So looking at how we can provide care to our patients holistically, kind of more on the risk basis. So we take the risk and taking care of their chronic diseases, keeping them from developing into more acute conditions and so on. And that the more that we can do that, actually, is kind of win-win for the patients, for ourselves, and also financially. So that's one of our focus areas. The other thing is what we have what we call the digital-first strategies. Kind of again, we look at how we can deliver care in a more efficient way that you don't have to invest in a lot of brick and mortar, heavy investment, capital, and really focus on how we can really capitalize more on video visits, e-consults, and things like that. So I think we're still kind of in the tip of the iceberg. I mean, COVID kind of drove us to, everybody had to implement some of these digital platforms very quickly. So we kind of relooking at, so we kind of have some Band-Aid approach over the last couple of years, and now we're looking at more holistically again across our platform and see how we can collaborate better, and even between Every Clinic and Polyclinic, because we have some specialties that we don't have with each other. So how can we capitalize on these digital platforms to be able to care for our patients collaboratively across the two organizations? Because geographically, if you ever drive from Seattle to Everett, it takes like an hour. So most patients, it's not like the patients would very much be willing to drive back and forth. But if we have other ways that we can deliver care to the patients, either it's good for the patients, it's good for us, and it's also more cost effective if we can capitalize on the digital platform. So that's a big focus for us right now.
Great, thanks, Jennifer.
I don't like this thing. Okay. So being so rural as we are, we have real access to care sort of concerns. Like the nearest hospital or really medical facility is over an hour away and over a pass and in the snow. And so different from rural where you're close to somebody, there are other questions. So right now our focus is on our EMS services, which we don't own, but because of the structure of the service, it's all BLS and no ALS services, which so we're trying to figure out how we're going to get some ALS services to our county. So that's a main thing we're looking at right now, and then just realizing that we don't have to be everything to everybody, but we do have to provide the necessary care that's going to save lives. So that's kind of where we're at, and collaborating with our local partners, our partners in Spokane and across those mountains to provide the specialty care that is necessary. Building up our scopes and our screenings about the scopes and that sort of thing. But my hospital came through a real rough time in the last 6 years, from no money to now we're doing pretty well. So now we're doing pretty well, and we got to look at what keeps me up at night is our building is old, and how to get the capital to keep the building going. So that's main thing on my list this year too.
Very good, thank you. Richard?
Yeah, capital is a real dilemma. This year we're embarking on a new bond program. I've never done a bond before, so that'll be interesting. But I'm sure there's lots of consultants out there just ready to help me, right? But yeah, the facility, our facility is an aging facility. We're going to have to update HVAC. Probably every person on this panel or in this room is trying to figure out how am I going to comply with the new green mandate coming out of the State House, right? So that's a dilemma for us that we'll be trying to address as we think, and we have to do that to maintain our ability to meet the needs of our community. And as we think about moving into the future, it's East Lewis County, which is similar to your area, but the internet runs right down Highway 12, and if you're within a half a mile of Highway 12, you probably can get it. You can get a wired access, right? Otherwise, you're on to Starlink or HughesNet or something like that with a lot of delay, and it's a real challenge. And the cell phone, if you're on the backside of the mountain and the tower's on the other mountain over there, you have no signal until you drive around the mountain, right? And so that's a bit of dilemmas. But, we're trying to figure out how can we bring our community into the 21st century with telehealth. And there's a real aversion to that in East Lewis County. They really want their Facebook, but they're really concerned about what they're going to send over the internet in terms of their health. And that concern is probably not just East Lewis County, that's probably prevalent everywhere. And this digital adoption, I think if you look at the average age of Lewis County, you're going to find that it's above 55. And so it's a lot of old school thought processes, if you will. And so trying to bring them along and help them realize, look, it's just like looking at your grandkids on Facebook, right? Or, something like that, something to get them to engage in the process. And that's just half the battle, because the other half of the battle is now you got to go talk to your providers and have them realize, hey, you can do this digital health visit on telehealth. Just because the pandemic is over, it doesn't mean we should stop that. There's still a value to that. It doesn't need to take forever, and their complaint to us is like we heard earlier today, I get tired of looking at somebody's neck when I really want to look at their face or at their arm or whatever it is, because they're pointing the camera at the wrong place, right? So those are some of the battles that we're facing. How do you solve all those things? It's repetition over and over again, and we all get tired of that, but that's how change occurs, is repetition. And so coming up with creative ways to move folks there. For example, we have one of our docs got snowed in over the last snowstorm that came through. He was up on his house. Unfortunately, he got COVID at the same time, but it was great because you could stay home, you could do your telehealth visit, and you wouldn't impact anybody with your COVID, so you were able to keep working, right? It's a win-win for everybody. I think it's a win-win for everybody. So I tell my clinic manager that, and she's like, yeah, I'll work on that for you. And those clinic managers, they are so important, just like whether it's a clinic manager or any type of manager on a floor, they are the ones that are closest to the situation, and building that relationship with them, like Ketty said, is so important, because they're going to be the ones that have to go out on the front line and implement these great ideas that somebody in my glass crystal castle came up with. So I always tell my managers or any person in the organization, I have great ideas, but I got to use you as a sounding board to make sure that they're on target. And I need you to redirect me or let me know what the dilemmas are, because we have all these great initiatives out there like digital and annual wellness visits and joining ACOs and things of that nature, but it can't be just a great idea coming from the C-suite. It's got to be bought into across the organization in order for it to be a success.
Thank you. Just a couple more things to add from our organization. We certainly have a community that has a lot of social challenges for our population. And one of the things we're really focused on is trying to deliver care at the lowest cost and in the right setting. So our organization's really been focused on serving the patients where they need it. We've done a lot of work in the home space. We applied for a waiver to be able to provide inpatient level of care in the home, where we actually have nurses that go out and provide inpatient level of care in their very own bed, in their very own living room, and still be able to bill for it as a hospital visit. We've also really have been pushing our home care with our partnership through Dispatch Health, and working with a variety of different service lines and services to deliver care at home from a ARNP, and really focused on, can be utilized in a lot of different ways. It can be utilized by, getting that patient discharged from the ED with maybe a follow-up visit from the Dispatch Health the next day that would avoid a admission, right? So that's one of the things that we're looking at. We've also been doing a lot of work within our facility to try to optimize our throughput process. We we didn't have very good utilization around our discharge lounge, and so we've revamped that process and put in some navigation resources. We're really focused on eliminating barriers to discharge. So that's been a big focus, and then certainly focused around growth. Puyallup's an interesting market because you're kind of close to Tacoma, you're kind of close to Seattle, and so we want to be able to provide services in the community. We've been a community hospital, but we send a lot of high acute services outside of our community, and so just really thinking about where's the right balance to be able to care for that in our own community. Certainly you have to have the right volume to keep your clinical competencies up, and there's certainly investments in new technologies. Some of the things we think about as it relates to capital funding around some of these things is, do we look at models where we're doing a per click basis model versus an outright capital purchase investment? So a lot of different types of strategies there. But certainly, length of stay is probably our number one focus right now from a financial recovery perspective, as we look to lower the cost of care and care for patients in the right setting. So now is my favorite part that we're going to transition into, which is hearing a little more on the personal side and just find how do we find balance in the work we do, but also just some advice around career progression and any advice for people that are looking to grow their careers within the healthcare industry. We have about 20 minutes left, and I want to make sure we have enough time for questions. So maybe 2 minutes from the panelists, and then we'll open it up for questions from the audience. Who'd like to start? I'm going to do that this time. Mix it up. Don't y'all jump at once.
I'll start. That's fine.
Okay.
So for me, I think my career, I've taken a little bit of, if you look at my career, a little bit of random walk. I've taken kind of different roles, and one of the things I've learned that, especially for the finance person, the more you can learn about operations, the more I think it actually really helps, because you can speak the same language, you really understand the challenges and the issues that the operators are facing. So I work on some really interesting, amazing project when I was at Northwest Hospital that involved, one of them was involved setting up radiation therapy services, buying the linear accelerator and working with the operator, working with the doctor and the operator to get it all set up. I remember I was taking the ceiling tile picture, like when you're lying down, doing your red-on therapy, there's a picture on the top of the ceiling that you can look at. I remember sit down with our oncologist, like, which picture would be good? Like, you had to voice certain things. That it was kind of really interesting. And then I also had the opportunity to actually oversee the diagnostic imaging department at Northwest Hospital for about 15 months, and it's a pure eye-opener for me, just being there and understanding, seeing a different side of the hospital operations that I would never have seen had I just been sitting in my office, in the administration, right? So my advice is that the more you can reach out, the more you can get into operations, whether to understand them, just build a relationship, ask them to give you a tour, or you've had the opportunity to just take a little deviation or diversion for a detour for your career, and to me, that's been very, very helpful.
Thanks. Who's next?
So I kind of gave you the brief sketch of my career path as I've grown up, but I guess I'll give you a little more of the family view this time. I told you my wife's an accountant, but what's really interesting in my family is my father is a physician, my mother is a nurse, my other sister is a nurse, and we talked a little bit about agency earlier. She spent several years at Riley Children's Hospital in Indianapolis and then went on the road as an agency nurse and saw the world, and so that she would share those experiences with me. My youngest sister, 10 years younger than me, worked at Florida Hospital and started in the cost accounting area at Florida Hospital, and today she does cost accounting for all of Advent Health. And so, to Ketty's point, if you want to grow your career, you need to make sure that you reach out and find ways to get into other parts of the hospital, which is exactly what I did. I was at a medium-sized hospital in Advent Health. I got to know the surgery director. I got to know the lab director. I got to know all these different folks and got a lot of different experiences from them that I take with me as I go through my career. And I think that's invaluable. I think back to my CFO at Advent Health, and I think a lot about the things that he did with his staff. As he was coming up through the system, he did the exact same things. He was out visiting all the different areas, even though he was just a controller at the time, and getting to know, and he took all those experiences up. And today, or as I interacted with him at budget reviews and things like that, he would ask those insightful questions of, well, what does your lab team think about this? Because I remember at Florida Hospital when we did that, we fell flat on our faces because we didn't think of this. And so you take all those experiences and you try to ingrain them into yourself so that you have that viewpoint going forward. I can't tell you how many times I've been back to my parents' place and we're driving to somewhere and Dad says, now tell me again what this Affordable Care Act is supposed to do, and right on down the line. And so you get that physician point of view interacting with you, and it's challenging you to think about what's going to be the impact to them. And of course, you can never forget what dear old mom says, right? Just remember the nurses.
All right, Jennifer.
So I agree with the operations side, but I thought that was just because I am in operations. But I think I am in operations because rural health is my thing, right? So if you're, I guess I'm from a rural health perspective, if that's what you're interested in, then learning the way that a critical access hospital is paid and how that all works, because it's really counterintuitive to us as finance accounting people. You can't cut expenses to success in a critical access hospital, and that's real counterintuitive to most of us accountants. But as far as I think I found working through budgets, that really got me into operations and knowing all the departments, and then on the cost accounting side, we built a system, and just visiting with all the department managers and leaders, that really helps you be able to speak the speak, and I think that's where you can lend your expertise in the room, in a meeting, in a very insightful way that they might not even think about. So that's I agree with the operations part. As far as balance, I think I haven't slept for like 3 years now, so I don't really know about balance right at the moment, but I do get outside and kayak, and that little grandbaby of mine has helped a lot. So that's me.
That's great. I think the only thing I might add is do something that challenges you. So if there's something you're afraid of, take it on, volunteer, find a way to do it. So when I started my career, I was petrified of public speaking, like absolutely petrified of it. And I remember the first time I had to do it, I was like nauseous, I think, all weekend. And I did it, and I survived, and I did it again, and I did it again, and I did it again. And now I can get up in front of like 500 people without preparing and feel very comfortable in my own skin. So I think do stuff that pushes you outside your comfort zone. I would also say the advice that I always give everyone, and Sean talked a little bit about this yesterday, and we were talking about it at our table, is do something you love. If you do something you love and you invest in your passion, you're gonna be successful, and you're gonna live a more well-rounded life. I was on the panel last November. Many of you have heard my story. My husband committed suicide in January of 2021, and I instantly became a single mom of 3 boys, one who's autistic and has special needs. And I really, really woke up to having to have that balance. And so I really, really would encourage everyone to, if you feel like you're being sucked into that work hole, that you just put it all in perspective and, again, do something you're passionate about and that you care about. That would be probably my advice. So I want to thank all the panelists for all the prep work on the questions, but now's the fun part. We get to turn it over to you guys. And Jesse looks like he's already ready for a question. He's been waiting.
I'm ready. In fact, thank you, everybody, first of all. And then I've got a question. Well, actually, I've got a comment that, speaking of public speaking, you're looking at your chapter president here in 2 years. So just so you guys know, you guys have a great leader. We have a great succession plan.
I got big shoes to fill.
So, the question I had, too, but he also spoke about as far as following your passion and everything. And last night at dinner, we had dinner with a lot of people that I work with, and Ketty was there. And Ketty, I'm wondering if you would be open to sharing your next step. I think is something that's you're passionate about, and you're able to, your next step.
Okay. Oh, great. Just keep talking. So, yeah, the timing is a little awkward because I was asking Jesse, well, I'm coming, but I'm actually quitting Optum. I'm going to take on a CEO role for a local nonprofit called Kinon. Still kind of in the healthcare in a different capacity. Kinon offers senior care specifically for Asians in the community. They operate a 100-bed skilled nursing facility. They have assisted living and other healthy living programs. Again, culturally and linguistically Asian. So something I'm more passionate about, serving the Asian community. And talking about doing something scary, taking me completely away from the finance track and now going to operations, completely kind of holding my nose and close my eyes and jump in the deep end. So it's an organization that is, I actually have been volunteering on the board, and something I'm just more passionate about, just really want to do something back for the community and go back to the nonprofit world. So that's what I'm doing. So, yeah. Yeah, it's only a mile from my house, so that's also great. But just because I live in an area that's very, very diverse in the South Seattle area. So again, giving back to community. Well, I don't even want to say it's giving back, it's just serving the community. That's something that I'm really looking forward to.
Great, more questions. Be brave, ask a question. Take on the challenge. Oh, there goes Kale. All right. Thanks, Kale.
Okay. So we talked a lot about the expense side of things, but I'm curious on, and I know everyone has a different perspective on payers and kind of what's going on in their facilities. There's a lot of different things going on. I know one of them is that, there's certainly a shift to more outpatient settings from inpatient settings. So just curious on your perspective around what that is to you in your area, and maybe any other thoughts you have on that.
Value-based contracts. That's our answer.
Value-based is a very broad term. And it's important looking to how, so I told Marnie, let's not ask the how do we take cost out of healthcare question, because I get so tired of that. But at the end of the day, the two models, the PPS model versus the critical access model are built on two different approaches to healthcare. One is the minimal approach, critical access, what can you do to get by, and we'll pay our fair share of that cost. And the other is, this is how much we're going to pay you, and you figure out how to do it, so it becomes a volume number, right? More volume pushed through, the better operations we have. It solves all of our problems. So how do we make that work? Well, value, I think, is the beginning of that conversation of getting back to how can we lower the cost. But it works the opposite way in a critical access organization, because as you start to, I was thinking about this question this morning because I knew it was going to come up, and I thought, I don't mean to demean our critical access organizations. We're great organizations. We deliver the right amount of care. But in our journey of we've just sought DNV certification at Arbor Health. And in doing that, we've recognized that there are some, I'm going to use the word deficiencies in some of the things that we do. We may not track this. We may not do this item. Or we decided we're going to become a stroke center of excellence, or whatever the case might be. And that means that we have to bring more resources in to deliver that type of care, or more cost in to deliver that type of care. But we still have the same population that we're working with. We still have less than 10,000 lives. And so as we try to grow and become a better quality organization, we're introducing more costs, more expertise. We have to bring in nurses or physicians that have that expertise, and that introduces more costs. And then when we get to an ACO and they say, well, your costs are out of line. In the ED, you have a lot more ED visits than you should. Well, that's because the ED is the gateway to care in our community. So how do we balance those two dynamics? And that takes a lot of creative thinking to work your way through, and a lot of creative conversations with your ACO partners who are saying, you got to come along and figure out how to reduce this number with us. And I'm like, that's the gateway to my organization. How do I reduce that number? It has a direct relationship to cost for us.
We have time for one more question?
Sure.
We've got a question in the back.
Here,
I want to see some running, Jesse.
Yeah, that's right.
Thank you, everybody, for your time up here today. Again, we really appreciate it. On behalf of the vendors, not that they let me speak for them or anything, but and not particular to any service line or technology or anything like that, but in the climate that you guys find yourselves in, how can we support you? What are you looking for from your current vendor relationships or future vendor relationships? What are you looking for in that engagement? Where's areas of value that you're hoping that you can lean on us for? What do you want to see in contracts? What can we do to support you guys? Because we do want to bring value to the relationship, and your world is changing so quickly. So yeah, I think would probably like to hear that from you guys. How can we support you better?
I love that question. Thank you. I talked a little bit, I was kind of making a joke yesterday about robot nurses. If you can help invent a robot nurse, just kidding. I think a lot about how do we automate things, right? How do we drive our labor costs down? How do we we have so much shortage in our labor market in terms of the number of bodies we need. So that's probably, I would say, the number one thing I'm thinking about. I would also say probably speed of execution and implementation on some of our products. The faster I can get something in the more seamless that process is kind of what I'm looking for when I'm having conversations with different folks. Yeah. You guys have anything to add?
Partnership. I want a partnership with my vendors for sure, and to be able to lean on your excellence, because that's why I've got you.
Yeah, I agree. I think innovation, automation, but more importantly is that partnership. So we need vendors who really listen to our needs and not just trying to sell us what you already have on the table, but really understand what our needs and how we can partner and how this can really be a win-win relationship. So.
All right. Did you want to add anything or? All right. Well, this has been a really fun hour and 15 minutes. I hope you guys enjoyed it. I know I learned a lot, and I just want to thank our panel again, because they are amazing people. They're very busy, and they took time out today. So thank you.
Well, thank you all.